So, good evening, everyone. So, it is wonderful, wonderful, wonderful to be here this evening talking with two amazing and phenomenal Black women that work in a space that is near and dear to my heart. So, my name is Dr. Valencia Walker. I am a neonatologist, and I also have the incredible privilege and honor of serving as president for our Birthing the Magic Collaborative. Tonight, I want to introduce again two incredible people. First, I want to acknowledge Mia Malcolm. Mia is an advocate, and it's not just a title for her, but it's truly who she is. She works as a DI advisor and program manager for equitable parent family centered care at St. Louis Children's Hospital. Now, you're probably wondering, hey, that's her name, that's her title. How did she get here to this space? And that's really important. Her journey started with the birth of her son, Gavin, 13 years ago, born at 24 weeks. The idea of her NICU experience really transformed her and showed her how she could redirect her work and her purpose. She has served on several local and national committees and task forces related to DEI and healthcare. More importantly, she has become such an effective advocate and a voice for families and communities, particularly our Black communities that have been historically excluded, have had resources taken away, and how we change the narrative and really learning how to thrive in places that are predominantly majority, like our hospital systems. In addition to Mia, we have Dr. Carol DeWalt. Dr. DeWalt is also a board certified neonatologist, and she is passionate about how she cares for babies. The one thing you'll learn about most of us as neonatologists, and I tell people this all the time, we love all things cute pink baby toes. If you've got cute pink baby toes in your life is automatically better. And so she advocates for newborns and their parents. And really, it's about empowering them with knowledge so that they can speak for themselves and navigate those challenges of parenthood being presented in a way that's very different and truthfully, honestly, often very traumatic. Now, she has put her passion into action as the founder and CEO of Newborn House Calls MD. And this, through her company, they are dedicated to providing comprehensive care to new parents and their babies. Notice I said parents, not just mamas, because what we also know about our communities is that it is about the village that nurtures and raises all of us. And I think as a mother, and the own challenges that she faced and the own anxieties, like, hey, y'all, just being a doctor doesn't make any of this necessarily easier when you're going through it. She brings that genuineness to her work, similar to Mia. And that's why I'm really excited to have them here with you today. Now, we are a little nerdy. We do want you to get information. So Dr. Carol is going to start off with a presentation, but then we're really going to have a conversation, because it's in those conversations where we're just keeping it real with each other, where we really make a difference. And we want you to walk away knowing that you can change the narrative around how we get healthcare, particularly for our babies in this country. So Dr. Carol, let me turn it over to you. Thank you.
Thank you, Valencia. That was beautiful, and I am so honored to be here today. I am, like many of you, when I was pregnant with each of my children, I had an amazing sense of expectation, but also a fear of the unknown. Also, like many of you, I sought information and education to help me prepare for this unknown future. And I went on, like many of you, to have parenthood show me many journeys of joy that I could not have foreseen, and also that I could not have imagined. And I went on to become a board certified neonatologist and be the person that helps parents navigate the unknown waters of early parenthood. And now, after 16 years of neonatology as a neonatologist, I take so much joy in it. I'm so honored to be here today. I'd like to dispel some of the mystery of the NICU and also discuss some of the challenges of being a parent to a NICU baby. So I'll be presenting how to nurture your NICU baby. So having a child in the NICU presents certain challenges. I have no disclosures. And I'd like to first start with who is a NICU baby? So the NICU is a very special place. We take care of babies who are inherently in need of intensive care. And there are a wide variety of babies who come to be there, spanning from babies who just have an infection and maybe with us for a few days, to babies who are born extremely premature and thereafter remain in the NICU for several months. A premature baby is defined as a baby who was born prior to 36 and 6/7 weeks. And a term pregnancy is anywhere from 37 weeks up to 41 and 6/7 weeks. There are many categories or several categories of prematurity. We have a micropreemie, an extremely low birth weight baby who is less than 1,000 grams, very low birth weight babies who are less than 1,500 grams, and low birth weight babies who are less than 2,500 grams. So as you can imagine, there are several challenges that come to having such tiny, tiny babies that start with being unable to breastfeed immediately. NICU mothers cannot have their golden hour where mothers are able to go skin to skin with their infants and infants are able to begin breastfeeding on their own. And then there's the separation of the mother-infant dyad. Therefore, being in the NICU can be emotionally distressing, and also that separation creates challenges. And many parents experience a loss because they are not able to have their Gerber experience. They're not having the emotional experience that they expected when they found to be pregnant. And that sense of loss in and of itself is something that can contribute to a certain amount of depression and more severe symptoms of anxiety and post-traumatic stress disorder that as a NICU doctor, we try to help parents navigate through. So one of these ways is helping parents to develop emotional bonding. And in the NICU, we use a very powerful hormone called oxytocin. We do what we can to increase oxytocin levels. And oxytocin has been called the cuddle chemical or the love chemical. And so we do this by decreasing interferences to oxytocin release, limiting pain, because increased pain decreases oxytocin. So we encourage mothers to stay in front of their pain control. We recognize that breast surgeries can limit breastfeeding. And so we actually discuss with OBs, if you have a mother who has had breast surgery, that they are aware that they could have breastfeeding challenges and breast milk production challenges. In addition, in term pregnancies, you can do breast stimulation prior to baby being born, and you are able to produce breast milk prior to birth. With that being said, breast stimulation can anecdotally lead to spontaneous labor. So we don't necessarily recommend that you stimulate the breast in preterm pregnancies, but in term pregnancies, that can help breast milk production. And then last, or also reducing stress and this fear and embarrassment around breastfeeding so that mothers feel comfortable, so that oxytocin can be more easily released. And fathers can really help reduce stress by helping take care of the baby and allow mother to rest, wash bottles, wash pump materials, waking up in the middle of the night to do help hold baby and to allow baby to go back to rest, and give mom a break and so that her oxytocin release is more efficient. Avoiding alcohol consumption and smoking can improve oxytocin. And then recognition that concurrent illnesses can interfere with oxytocin release and therefore limit and cause challenges to milk letdown so that mothers don't feel extra stress and so that every effort is recognized. So in the NICU, while we talk about breastfeeding, we really stress breast milk production initially. Breast milk is the first step. And preterm infants develop the ability to suck, swallow, and breathe generally about the 34th week of gestation. Therefore, the major challenge initially will be just mother to produce the milk while awaiting baby to be able to start feeding. So neonatal nurses, postpartum nurses, lactation specialists are all present to help mothers learn to pump and get pumping initiated immediately while their baby's in the NICU. And it is important to note that pumping activates the cuddle hormone as well. The very first breast milk is called colostrum, and every drop of colostrum counts. And I call them drops of gold because they are power packed nutrition. They're very, very powerful, and they are very, very useful to starting baby's nutrition. And breast milk is a dynamic fluid. Colostrum is high in protein, and the breast milk actually changes throughout the course of a day, throughout the course of a feeding, and throughout the course of the breastfeeding months. Now, colostrum is generally only formed during the first 1 to 5 days, and then there's transitional milk, and then mother's mature milk will. And as an example, colostrum has high protein, like 3 grams per milliliter. Transitional milk has 2 grams per milliliter, and mature milk has about 1 gram per milliliter. So that initial colostrum really is giving baby a powerful start to feeding and weight accretion. So that being said, there are different types of proteins within breast milk. The primary proteins are whey and casein. And the reason I bring up whey is because whey has a certain type of protein called alpha-lactalbumin, which is different than the protein that's in cow's milk. And the interesting thing about whey protein is that it is soluble and remains in solution after acidification in the stomach. So that leads to better stomach emptying for babies. So it's important that parents know that breastfed babies can poop and pee with every feeding, and they don't necessarily have diarrhea, even though they could have 8 to 12 poops in a day. That's wonderful, and that's related more to the protein that is related in breast milk. The other components of breast milk are protective factors like immunoglobulins, which help give baby protections against infection. They're enzymatically active factors, and they're also macro minerals like calcium, phosphorus, iron, and zinc. So it is important to note that preterm infants are different from term infants, not only because they have delayed feedings, but also because they are at risk for a different subset of disorders like gut diseases. One particular gut disease is called necrotizing enterocolitis, and for short, we call it NEC. And we know that breast milk is protective against this gut infection or this gut disease. It's not exactly an infection. We don't completely know what causes necrotizing enterocolitis, but we do know that breast milk is protective. Breast milk is also neuroprotective as well. And we also know that breast milk helps to decrease the incidence of retinopathy of prematurity. Retinopathy of prematurity is where the blood vessels in premature eyes grow a little bit differently, and they don't grow necessarily as healthily as term babies. But breast milk is protective against retinopathy of prematurity. So breastfeeding gives specific benefits to premature infants. In addition, the exact incidence reduction of necrotizing enterocolitis is 77%. They are also protected from hospital-based infections. They have fewer hospital readmissions in the first year after NICU discharge. They have improved long-term cognitive development, and this includes pasteurized bank donor milk, and they have the better acuity related versus infants who do not receive breast milk. Now, one interesting fact is that all women do not make the same breast milk. And their differences in breast milk can be related to the actual diet that mother has. If mother has a diet higher in fat, then she will have breast milk that's higher than fat. And the range in calories of breast milk can be anywhere from 13 kcals per ounce up to 35 kcals per ounce. And in general, though, we say that the caloric density of breast milk is 20 to 22 kcals per ounce, but is heavily related to mother's diet. And so I wanted to stress that both breastfeeding and breast milk are important, but breast milk is also important alone to reduce long-term effects after discharge. They've been found that 72% reduction in risk for hospitalization, and this is for term and preterm infants, 50% reduction in inner ear infections, and breast milk is protective against sudden infant death syndrome. So one of the things is that when infants are in the NICU, they are not necessarily feeding immediately, and it is important that they do receive breast milk. So the AAP recommends that all preterm infants receive human milk. Now, some mothers have challenges to creating human milk, so we have donor breast milk banks, and these include pasteurized donor milk, and it's available and recommended that all infants, preterm infants, receive donor breast milk in the event they do not have mother's own milk. The WHO and the AAP recommend that babies receive breast milk for the first 6 months of life only, or breast milk only for the first 6 months of life, and that they receive breast milk through the first year of life in concert with food, which should start at 6 months of age. Preterm babies also have breast milk fortification. Human milk is supplemented with a multi-component fortifier that increases calories and also increases the content of iron and other elements. Breast milk has lower content of iron, so it is recommended that babies who are breastfed are iron supplemented. In addition, it's important that we're providing enough volume. So as mom is breastfeeding, we recognize there are challenges to breast milk production. So sometimes formula is necessary. And just a word about formula. There are different types of formula, and preterm babies should receive fortified formula. In general, they should receive the fortification until about 9 months of age. And there are many categories. But in general, the content of them, if they are Similac, Enfamil brands, are similar to each other. They just vary based on caloric density. And a word about soy-based formulas, they are not recommended for preterm populations due to risk for osteopenia and less growth accretion. So that being said, it's of great concern that we improve breast milk production. We recommend that all mothers receive help of a certified lactation consultant, that they employ correct positioning, correct latching, that we pump immediately so that we're telling our brains that we are breastfeeding. We recommend pumping for 8 to 12 times a day and offer both breasts at each feeding. And one of the greatest hindrances to getting full breast milk production is that mothers aren't emptying their breasts. So it's important that each breast be emptied at each feeding, especially at the beginning of breastfeeding initiation or breast milk production. We recommend that mother gets plenty of sleep and she eats a well-rounded diet, because both of these things increase oxytocin release, and therefore that she has a moment to relax and also provides massage to her breasts, and that will decrease her cortisol levels. We talked about fortification. I do recommend avoiding an all or nothing approach to breast milk. So sometimes we do have to supplement with formula or pumping, and when baby is able to latch to the breast. drugs that stimulate milk production are called galactagogues. We recommend that first we employ all basic activities like using correct positioning, seeking the help of a board-certified lactation consultant, and then we would discuss with your doctor about stimulants for milk production. So I did want to talk a little bit about my story. I am also a NICU patient. This is a picture of my mother, my father, and I. And my mother had me at 28 weeks gestation, and she was a nurse, and she was able to take me home at 30 weeks gestation. And so you can only imagine the struggle that she had at home with a 30-week baby, where she had to feed me through a tube. So my endeavor is to communicate that the world of neonatal nurses, specialists, and doctors are here to help. We're here to provide education. We're here to support and to give your infant the best outcomes possible. Thank you.
Thank you so much. And also, thank you for sharing your personal story. I cannot imagine trying to have a baby that's born more than 2 months premature at home. One of the things we know about babies at that age, like they literally don't even have the ability to feed, use a bottle. So kudos to your mom. That's amazing. Now, as we mentioned, we really wanted this to be about a conversation. And so at this point, I want to kind of turn it over and let's just talk. You gave us a lot of information about all the numbers we should think about and all the fancy hormones and how all those things happen. But I kind of want to talk a little bit of just nuts and bolts. And so I'm going to maybe direct this first question towards Mia. Either in your experience or through your work in the NICU, what's it like when they're like, okay, let's try breastfeeding your baby?
I think that I will say, like, for me personally, it was, I don't know, it felt weird. Like it didn't feel natural. You know what I mean? Because like Gavin was born so small, he was a 24 weeker, and like, so it wasn't like, a week later we were gonna try breastfeeding, right? Like we went on a journey. And so like by the time that was even brought up to me, I was just kind of like, I mean, are you sure? Like, am I supposed to? Like, I mean, like, it's the same stuff in a bottle. So, like, just give him what I pumped and it's in the, like, that felt more real to me. Um, and it was like a lot of conversation around, like, it's okay to try. Like, you know what? If it doesn't work, fine, we have a backup, but you should try. Like, but it just felt weird trying to like establish this new bond with him because we already had a different bond. Like I would, you know what I mean? It felt weird. And I see a lot of, especially of micro preemies, a lot of um moms or birthing people like really struggle with that connective tissue because it's not the relationship that you've built with your kid thus far. So
If
yeah.
there are people who are on the call that maybe have not had the experience of a child in the NICU, one of the things that maybe we should do is kind of quote unquote set the scene.
Yeah.
When your baby is born premature or when something goes wrong after your baby is born, there is a lot of trauma. And whatever you thought your identity as a parent was going to be, it's often destroyed. And I see both of them shaking their heads. Um, and after you've been either directly yelled at or chastised or discouraged, don't touch your baby, don't do this, or your baby doesn't get this, something bad is going to happen. It is a really challenging shift to go, wait, we're not in a normal place. My baby is not normal and healthy, but you want me to do something that's supposed to be natural and easy. And that can create a lot of anxiety. in and of yourself, because then it's like, are they going to judge me if I do it wrong? Or what if my baby can't do it? And is that another thing that's going to be wrong, right? So I told you, we're going to be real. We're going to have real conversations. So when you say that it's weird, I think that's honest.
I also, to the point that you just made, it was there is like always this voice in the back of your head of like, if I try and it doesn't work, we use the word fail a lot in NICUs, right? Like the failure to thrive or failure to extubate, right? And it's like, is this one more thing that I'm making my baby a failure at? So it's just easier to not, because it's just like, I don't want to be the reason that he fails again, right? And it's that trauma and that constant voice, because you're not at home and you're breastfeeding, but like everybody's watching you. Like the lactation specialist is there, the nurse is there, like everybody's there, and they're like, are you gonna do it? Is it going right? She's like,
I'm
yo,
laughing and I shouldn't be laughing, but it's
it's
because
so much pressure. It's like pressure when you're in the hospital with your baby. It's pressure, and like it's hard. It's hard because you don't want to be a failure, and you don't want to make your baby a failure again at something else that's supposed to be natural and normal. And you couldn't do the natural normal thing of keeping yourself pregnant, and now this is another natural normal. It's that constant guilt and like push that you have with yourself. So yeah.
Carol, did you want to add to that?
So Mia, what made it, if there was a moment where someone helped, what would you say it was?
I think that especially during my stay in the NICU, and a lot of times it was my nurses, because they were with me all the time, right? They were, our doctors kind of went in and out, but like that nurse was there for like 12 hours and 3 days in a row. And then I'll be back in 2 days. Like, let me know how your progress go, right? It was like every time I thought something was like too hard to do, or like I was afraid to like go and do that, it was always them encouraging me that like, this is gonna be okay. Like, good, bad, or indifferent, we got you, and like we will make a plan, but you can do this part. You can try, and it's okay. And it like, I never heard the word failure from them. I never heard that I was a failure or that G was a failure from them. And so it never felt like a pass fail thing when they
Yeah.
would talk about it. And then we had really good lactation people too, but it was really my nurses that like hyped me up.
So you bring up a good point, and I'm curious because I think this is important, right? How do you build community and support in the NICU? Because, typically the NICU is a closed place. There are only so many people that can visit. So not just anybody can come and be there with you and encourage you when you're in that moment. One of the practices that NICUs often have is assigning a primary nurse. The idea that when that nurse is present to work, that nurse will be assigned to your child. Was that something that was offered to you? Did you have a hard time with that? Was it those nurses that advocated more for you, or would you say it didn't make a difference?
So we don't have primary nursing at Children's. So I didn't have that. But what I did have was one Black nurse, and she is, when I tell you, she got me together on everything all the time. Like, I was so scared to hold him at first, because I didn't hold him for almost a month, because no one told me that I could. I was just like, I'm sitting there, I'm scared, he's connected to all this stuff. And she came in, it was the first time I had met her, and she was like, so what do you do today? What are you gonna do today? Like, what's your plan? And I was like, oh, he stays in there, like in his incubator, and then I sit in this chair and just watch him in there. And she's like, so when are you gonna hold him? And I'm like, oh, no. They haven't told me I could do that. She's like, girl, that's your baby. Get your baby. Come hold your baby. Like, sitting, okay, you know what? We gonna hold your baby today. What do you want to do? Skin to skin? Like, take off your shirt, let's go, let's hold the baby. And I was like, what's happening right now? We're moving so fast. But she did. She was like, this is your baby. You still get to be his mom. It's gonna look a little bit different, but you will be his mom. And so even with like the feeding stuff, it was her and my night nurses, a couple of them, but she was like, girl, you better feed this baby. He ready. He looking for his mama. Where you at? And I was like, oh, okay. Oh, okay, we're going. But it was, I don't think that people think a lot about like what those connective tissues really do matter. Cause she reminded me of my aunt. Like she was like, come on, girl, we gonna do this. You somebody mama. Like, let's be mama. And it was really, but it was that familiarity, you know what I mean? Like she just felt like home more than anybody. I didn't have a whole lot of people around that looked like me or reminded me of home, but she did. She reminded me of home.
And that is powerful. You mentioned the idea of skin to skin. So, Dr. Carroll, I'm going to direct this question towards you. Maybe let's elaborate on that a little more. One, can you kind of explain, maybe for people who aren't familiar, the concept of skin to skin and how it is a part of that journey to be able to feed your baby?
Babies are spectacular. They are able to do magic. One thing that happens if a baby's born, if you take the baby and you just put the baby on mother's chest after delivery, the baby will find the nipple, okay, all on its own. Okay, and there are these cute little videos you can look at on YouTube for that. But also, the interesting thing about skin to skin is that when the baby is in contact with mom or dad, skin to skin, the baby's temperature is regulated, blood sugar can be regulated. The baby is able to actually kind of have more respiratory regulation as well. It's just really powerful, that connection. So, the AAP and, all breastfeeding friendly hospitals, one of the guidelines is that mothers have the first 60 minutes of the first 60 minutes of life to have skin to skin for all these wonderful benefits that actually prevent baby from coming to NICU. But the thing is, so in the NICU experience, baby, doesn't get any of that. The irony is, though, when mother does start breastfeeding, whenever that is, even if that's 2 months later, all those benefits still go into play. Everything, the regulation, the breathing regulation, the babies who do have the mothers who are at the bedside and have that connection are able to actually progress more quickly. So, that same magic happens.
So just to distinguish, like in the term healthy baby, they're going to find their way there. But in those premature babies, skin to skin really kind of helps them learn how to do that. It also helps with some of those hormones that you talked about being released. And then you mentioned they're able to learn, help with regulating their temperature and things like that. So there are a lot of great benefits that we want to make sure that we think about. And so just like Mia was saying, ask to hold your baby. I'll give you another quick tip. Sometimes babies are really, really sick and they can't handle being touched or held. We've all been in those situations. But there are often times where it just takes a little more time and a few more people. And just like Mia was saying, if you don't ask, they'll be like, well, okay, on to the next. But you'll be like, hey, is there a respiratory therapist that can help secure the breathing tube so we can get G out of the isolette and I can hold G? Just because your baby has a breathing tube, just because your baby might have a central line, those in and of themselves don't have to be barriers, but it is a conversation. And sometimes you have to be the one to say, hey, I'm mama, I'm daddy, I'm grandma, my baby needs to be held. My baby needs to know how much I love my baby. And we often forget no one on this earth can survive without human touch, including the sickest of the sick babies. So I just, I think that's an important point that you made, Mia. And I'm so glad that you brought it up. Now, Dr. Carol, you were talking about like how a baby can find their way there. When a baby is trying to tell you that they want to eat or they're hungry, like what are some of the cues? I mean, obviously we're used to a screaming baby, but right, the little preemies, they might be too small to really, scream when they're hungry. They might not get hangry like I do. So what are some other types of cues that a preemie baby might tell you that's like, hey, feed me, please?
Well, there are, neonatal therapists, and they are trained to do like assessments. And we will generally start assessing around 33 weeks, 32 for some, depending on how big they are and how precocious they may be. And just to give them a chance, maybe just one, we'll see if they're able to suck on a pacifier, or we'll see if they'll suck on a finger, or, if we give them, we do mouth care with breast milk too. Breast milk is really powerful for seeding the microbiome or increasing the environment of the gut. And so we'll, see how the baby responds to that, and if the baby's able to swallow and suck and breathe at the same time. So breathing, sucking, and swallowing is a big deal for preemies in a coordinated fashion. It's almost like walking, because it's a big coordination that has to happen for all those things to happen well together. So that's what the neonatal therapist does, and the nurses.
And then Mia, what are some of the things that you noticed? Like it could be specific to G or just in general what you learned when you were in the NICU about cues to watch out for.
I think that, one of the things is that a lot of the babies are on like kind of regimented eating, right? For a little bit. So like every 3 hours, every 4 hours. So you just kind of start to look kind of like what Dr. Carol was talking about. Like they will start like making little sucking sounds, or, you see some of these babies and they are sucking on that pacifier for their entire life. What is happening? Where's the food? Something's supposed to be coming out of this. Like, where are we going? Like, what are we doing? And, for Gavin, he ate every 3 hours like clockwork. At like 2 hours and 57 minutes, you could see him like, look, he started looking around. Hey, where's she at? What are we doing? What's going on, y'all? So I think like you said, they might not have those cues like, term babies of like screaming their head off, but they will, they'll give you little signs. They'll pucker up their lips a lot. And typically it was like sucking on either his pacifier, or he would like get a finger or something and he would just start rubbing it. And I'm like, all right, I hear you, brother. Relax. I'm coming. But yeah, I mean, I think each of the kids, any of the kids, they all have like those general things, but then you'll notice like something specific with your kiddo and you're like, oh, okay, you're hungry. Got it.
So can I tell you a story? Maybe it's because of how much I love spending time with babies. I will often tell parents, your children are born with their personalities. It's just up to us to figure them out. So don't think that just because your baby is in an isolate in the NICU that they aren't trying to tell you who they are and express themselves. And even though the NICU may be a strange place, right? A really strange place. As a parent, you're the constant. Like she said, I love what I do, but I'm in and out. The nurses are there 12 hours working hard, but even they get some days off. No days off for you per se. Now, that doesn't mean you should be there every single day, because you need a break too. But you are that consistency. And so the more that you can say, I will tell you, at least for me, when someone says, he's not the same. This is how he usually is, but this is how he's been today. And I know it's a parent that has been there, and knows their baby. I'm gonna be like, oh, well, let me go back and examine one more time. So understand the power. Parenting may look different than what you expected it to be, but those are the kinds of things that save your baby's life, right? And that's so important. Now, from a cultural perspective, I want to shift gears a little bit, because there is this idea that Black women don't breastfeed. And I've often heard people talk about the worries and concerns that they have around breastfeeding. Mia, what type of messaging did you receive, or what kind of things did you worry about that maybe you had to learn after the fact?
I consider myself, especially for being a Black woman and like that idea, right, that you're talking about, I consider myself super privileged because like my mother breastfed me and I tell you, it's all she talked about. It's all she talked about when she found out I was pregnant. It was breastfeeding, it was a natural birth, and it was cloth diapers. Those were like her key parenting points. And I was like, no, I am not doing cloth diapers unless you were paying for a laundry service, because that's a lot. But like my mother breastfed me. I watched my aunt breastfed my youngest cousin until she was like almost 2. And I was like, what is happening here? And so like I didn't know, you know what I mean? Like I knew my mother breastfed me, but like I watched my aunt breastfeed. My best friend had my nephew a year before Gavin did, she breastfed. So like I saw examples of that in my life. And so the concept didn't feel or seem like foreign to me. You know what I mean? So I consider myself extremely privileged and lucky in that space that wasn't the idea of it wasn't like a barrier or like, something that I had to wrap my head around. It just had to be modified because of my birth situation was different than other people's in my life. So that's the only part that had to be modified for me, but I was extremely lucky in that.
That's amazing. I know for me, that's not typically the story that I have heard from a lot of people. Dr. Carroll, what have you encountered in terms of maybe things people have asked you that surprised you or that you had to try to educate people about?
I think usually it has to do with the all or nothing method, that people are like, I'm not going to only breastfeed, so then they'll go fully formula. Well, it's not an all or nothing. I think any breast milk is better than no breast milk. And so that breastfeeding is exponentially powerful for bonding, for nutrition, for immune regulation. So I just usually am talking to parents about, especially younger mothers who, for different reasons, maybe going back to work early, or they, have very active life. Just encouraging, how do we have any breast milk? Let's pump, and maybe we do, some form of breast milk, a few feedings in a day, and so that it's a like we're working together, coordinating and compromising with mom's life is usually one of the barriers.
So let's talk about that. Often our work policies are not friendly, and you got to keep the job that gives you the health insurance, right? So you're forced to go back to work. And so you're doing the best you can to pump, hopefully not in a bathroom stall, but again, your workplace may not be friendly. So you're doing the best you can. Ask people, put that label on your milk and ask someone else to drop it off at the hospital. Don't feel like you have to do it all. I think that's one of the things I encounter, that someone is trying to pump, they're trying to clean the breast pump parts, wash and sterilize them. Then they're trying to like store it. Then they're trying to get it to the baby. Divide up the task. Somebody else can sterilize and wash those dishes. You only have so many hands. You can't do it all. And so I think that's one of the things I've encountered. I think something we don't often talk about, and it really struck me in a very powerful way, is people that maybe have experienced assault, and how even just having to expose their breasts, particularly in a public place, can be really difficult. And we don't always have the words for how we talk about that. And if that is an experience that you've had or something that you're struggling with, I'll be honest, we might not be the best people to know how to handle it. But I think bringing it up, particularly with the lactation counselor or with a social worker or something like that, gives us at least an opportunity for how we can try to be more thoughtful and be more careful. Mia, I saw you shaking your head. I didn't know if you wanted to follow up on that.
Yeah, I think that see, I agree. We don't talk enough about those kinds of barriers. And I know that when it's come up like in my space with some of the families that I've worked with, um we also have like perinatal mental health resources at my hospital. So like getting them involved and even like asking that parent, that mom or birthing parent, like what do you need in order to feel comfortable and safe? And we made sure, like, even in our private rooms, right? The it's still a glass door and you can still see into it. So like if she needed another divider in front of that window, even if she was behind the curtain, like that would indicate to people that she was pumping and like, please don't come in because that was hard or triggering for her. And I just think that really conversations, like as much as we can talk to people to support them through their barrier instead of shaming them for their barriers, especially when it comes to something as important as providing milk for your kiddo, especially if it's especially if it's a premature baby, especially when it's a Black premature baby. I just think we have to do more of that. Because, I mean, if babies are going to be premature, our babies are often born smaller and sicker than anybody else's. And we don't have the best outcomes for a myriad of reasons. But anything that you can do to help support that family to get them through that it's just clutch. It's so important.
Now, we've talked a lot about once the milk is out and the benefit to the baby. Let's switch maybe back the other way. Are there certain foods, because I feel like I get asked this question all the time, that a person should be eating or should not be eating when it comes to trying to provide, quote unquote, the best milk you can for your baby?
So, I mean, first of all, a well-rounded diet is the goal. That being said, there are certain foods that increase gassiness, and gassiness can limit how much infant eats. Also, there are certain foods, some babies do have lactose sensitivity. And I generally don't necessarily go straight to lactose sensitivity right away and limiting mom's diet. Because that's really difficult. So I usually recommend doing that in concert with your physician and talking about it if you notice your baby's very gassy. But we know that like green leafy vegetables can increase gas, peppermint chocolate can increase gas.
So let me pause you on the chocolate, because let me tell you about how upset my friend was when she realized her baby did not like her eating chocolate. And chocolate was her happy place, right? That was her comfort food to help her deal with the stress and anxiety. And they did not get along. And I just had to be quiet, like, because people might not think chocolate, right? Like chocolate's supposed to make everybody happy.
The other issue is, there's some cultures that have like a chocolate drink that you drink in pregnancy. It's like, that's what, grandmothers give it. And then the baby has this horrible gassy, it's gas on another level. And so we have to have a conversation with grandma.
We're not saying to be mad at grandma. We're not saying that you can't eat chocolate at all. We're just acknowledging that there may be certain things that your baby might prefer over another. Mia, I saw you come off mute. What were you going to say?
Oh, I was just gonna say that's not my bit. I'm allergic to chocolate, so I don't have no issues with not eating chocolate. So that was not, but I love vegetables like green leafy, and listen, that gas is serious. It is something to know about your child. at a very small, tender age. So
You're
yeah.
like, we know the spinach salad you had today. Um, but I think Dr. Carroll, to your point, we want you to have quote unquote a well-rounded diet. I once met someone who drank a liter of Mountain Dew every day. And we tell you not to drink caffeine during pregnancy. And the baby had caffeine like withdrawal symptoms. And we couldn't figure it out until we talked to the mother and asked, like, okay, because you go like coffee, cappuccino, and it was Mountain Dew. So just realize that there are things that can affect your baby. Water, hydration is very important. If you don't like water, let's figure out a way to trick yourself into drinking more water. But as Dr. Carroll said, we don't normally tell you to limit your diet unless there's clear evidence, but we do want you to eat healthy. For babies that may have a problem with dairy, we may ask you to remove dairy from your diet, but usually that's after we have more like done more extensive tests and we're really concerned about how healthy your baby's gut is. We usually have you continue to take your prenatal vitamins and your iron, and so that type of supplementation as you continue, because we found that that can be helpful as well. Now, I think I have one last question I want to try to get to because the hour went by way faster than I thought it would. And that is, where are the resources for how to do this when you are parents of preemies and you're trying to figure out how to feed your baby? And when I say feed, I don't necessarily just mean, direct. Figuring out what's the right pump, figuring out the cycle every 3 hours. Like there's so much, how to get the right parts clean. There's so much we didn't get a chance to touch on in this hour, but where are the resources that you like or that maybe you try to recommend? Don't fight over it.
I think that there are a couple of things for me, like that I've noticed, especially with like pumps. Like I know that our lactation people will like immediately talk to you about like, who is your insurance? We can go ahead and get you a pump, right? Get it sent to your house or get it sent here, whatever makes you more comfortable. There are pumps in every room in the NICU, right? But I also think just really engaging your community. If there are people that are always there with you, like my mom was always there with me, and then Gavin's dad would come in the evening after he got off work. And to Dr. Carroll's point, after I pump, I'm not going to get up and clean all this stuff. Like I'm stressed, I'm tired now. I just want to relax. And my mom will be out, Mom, I need you to wash these. Okay. She's like, call me the Dairy Queen. I'm taking over for the milk. And his dad was the Dairy King. Like, they help to support me because it's tiring and it's exhausting, but it's so, so, so important. So it's okay to delegate and it's okay to not be superhuman in this process. Like, and even, especially with going back to work, if you do have to go back to work, one of the things that helped me, because I think it was easier for me to pump and stuff if I were at the hospital because I could see him, right? And then I had like this thing. So I made a playlist of songs that reminded me of Gavin, and I would play it while I pumped because it made me feel connected to my baby, right? And so I think like just little things like that are just from a parent, non-clinical type space. Those are just things that I've always found like parents found helpful and I found helpful, especially the playlist.
And I want to emphasize that this is not something you should do alone. We are used to having to be superhuman and be there for everyone else, but your success is your ability to bring people around you. Dr. Carroll, I'm going to give you the last word because we only have a couple of minutes left.
I really love the playlist because, basically what you were doing was harnessing oxytocin, looking at your baby's oxytocin with the playlist, bringing back the emotions, it's oxytocin. I I feel like in the hospital, people don't even know what they don't know. So I feel like we are the advocates to go through the checklist. Like, I know our nurses are really, primary team one. Our social workers, like you said, do you have insurance? If you don't have insurance, WIC, like, how do we get you a pump? Also letting parents know that the hospital pump is a little stronger than the home pump. So if you are having trouble initiating breastfeeding, using the hospital pump, which can be very affordable, and many hospitals actually have supplemental programs for them. So we're the advocates. Our nurses are the advocates. Once you get home, I know I created my company, Newborn House Calls, because I got home and I didn't know who to call, or I didn't have my mom with me at that time. I'm standing on the sidewalk like, what in the world? Everything's leaking and my baby won't latch. And I'm at the breastfeeding station for the third time. So, in the same week. So now there are a lot of companies you can call, like Newborn House Calls. We come to you, we help you breastfeed. We have lists of products and whatnot to hold your hand. La Leche League also holds your hand and has like a list of resources. So I think, just Googling even is, Dr. Google isn't amazing, but for this purpose, look for help. Early is better. So.
And often when you've had a high-risk pregnancy, you may not have been able to have the benefit of a journey with a midwife, but midwives and doulas, and there are a growing number of Black doulas as well, that can be additional resource and support. We're saying bring everybody on the team. No one person can do it all. So we are at time. We really hope that you benefited from this discussion. We tried to keep it real with you and talk about the highs and the lows, the stuff that's weird, the stuff that's scary, but also the joy that can come with navigating this space and knowing that you are empowered to love your baby, to hold your baby, to provide that liquid gold that is your milk. Again, we hope you enjoyed this session. This is, Prematurity Awareness Month. We do invite you back for a great session with Dr. Carol on November 29th, also at 9 p.m. Eastern Standard Time, 8 p.m. Central, and 6 p.m. Pacific Time. And it's titled From Belly to Bassinet, a workshop on newborn care. So we don't want you to be standing outside on the corner, leaking, not knowing what's going on. When is the cord supposed to fall off? Does this look right? Well, my mama told me to do this. Maybe this is right. So we're going to try to cover some of those topics, and we really look forward to having you join us again. Thank you so much. Have a fantastic evening.